Hi, I'm Peter Gloviczki from Mayo Clinic, Editor-in-Chief of the Journal of Vascular Surgery. Together with my co-editor, Dr. Peter Lawrence from UCLA Medical School, we are excited to bring you the November issue of the Journal of Vascular Surgery. You will surely enjoy reading the Editor's Choice article this month. Dr. Burgess from Burlington, Vermont, and his colleagues use data of the Vascular Quality Initiatives. Based on information on 88,791 non-emergent operations, the authors developed risk models for postoperative myocardial infarction after vascular surgery procedures, and they also designed procedure-specific risk calculators. The risk of a heart attack after all vascular procedures was 1.6%. The lowest risk was 0.8% after carotid endarterectomy, while the highest was 4.3% after open abdominal aortic aneurysm repair. Predictors of myocardial infarction included age, operation type, coronary artery disease, congestive heart failure, diabetes, creatinine over 1.8, stress test status, and body mass index. The model closely approximated the observed risk of postoperative myocardial infarction in the validation cohort, as shown in a calibration plot for all procedures. Similar results were found in the procedure-specific models as well. The deciles of risk of myocardial infarction based on cumulative risk are also illustrated in the manuscript for the 4 procedures that included open aneurysm repair, infrainguinal revascularization, EVAR, and carotid endarterectomy. The risk prediction algorithm was built into a smartphone app and website. To access the risk calculators via the internet, use the following link: www.qxmd.com, calculate online vascular surgery. Read this excellent article and start using the VQI CRI calculator. This is indeed a useful and valid clinical decision-making tool to predict myocardial infarction after vascular surgery. This month's CME article, Surgical Treatment of Abdominal Aortic Aneurysm in Infancy and Early Childhood, comes from the University of Michigan, and it is written by Eliasson, Coleman, Criado, and Dr. Jim Stanley. These aneurysms are rare, and evaluation of the etiology, presentation, and anatomy, in addition to the patient's age, are all important to decide treatment. The authors present their experience with 11 infants and young children treated for abdominal aortic aneurysms. These aneurysms can be idiopathic, due to unknown developmental defects and gene mutations, genetic, and in this age group the most frequent is tuberous sclerosis, mycotic, usually due to umbilical artery catheter infection, inflammatory, most frequently due to Kawasaki disease, or rarely traumatic, due to intense blunt abdominal trauma. The paper is beautifully illustrated with pre- and postoperative imaging, and it is easy to read. It will be most helpful to all of us who are involved in the management of abdominal aortic aneurysms in infants and young adults. The next highlight of the November issue is entitled Treatment of the Femoropopliteal Artery with the Bioresorbable Remedy Stent. It comes from Belgium and authors by Dr. Bontink and colleagues. Bioresorbable stents are an emerging technology, and the Remedy stent from Japan is the first commercially available bioresorbable scaffold in Europe for peripheral use. This prospective multi-center observational registry enrolled 99 patients with short femoropopliteal lesion, including 13 with critical limb ischemia. Technical success without major adverse event was 96%. Primary patency was 68% at 6 months and 58% at 12 months. Secondary patency was 85% at 6 months and 86% at 12 months, while freedom from target lesion revascularization was 81% at 6 months and 67% at 12 months. 2 patients had undergone an amputation. The authors concluded that the 1-year follow-up results of the remedy stent do not meet current standards set by nitinol stents, and that their use should be withheld until improvements are made and better data are available. Finally, results of a prospective randomized clinical trial of balloon angioplasty versus wire-bound stent graft for treatment of failing or thrombosed prosthetic hemodialysis graft is reported by Dr. Thomas Vesely and his colleagues. 293 patients with stenosis or thrombosed prosthetic access grafts were randomized to treatment with balloon angioplasty or wire-bound stent grafts. The study found that wire-bound stent grafts provided superior target lesion primary patency at 6 months for treatment of venous anastomotic stenosis or dysfunctional and thrombosed prosthetic hemodialysis grafts. These were just a few of the many excellent articles from our November issue. To access these articles free in November, please visit us on www.jvsurg.org. Enjoy reading JVS journals, and please remember to send us your comments and suggestions. See you next time for the highlights of the December issue of the Journal of Vascular Surgery.